Anesthesia services are also employed in different locations for various procedures throughout the hospital. Some of the common locations for out-of-OR anesthesia are in the radiologic suite, such as the computed tomography, magnetic resonance imaging, and interventional radiology, which may need anesthesia assistance, often due to lack of patient cooperation. Anesthesia may also be called upon the endoscopy suite for upper and lower gastrointestinal endoscopy, in the intensive care unit for invasive procedures such as bronchoscopy or central venous line insertion, in the cardiology suite for cardiac catheterizations, cardioversion, and insertion of implantable cardiac defibrillators. Other locations also include the emergency department, psychiatry, urology, and dental surgery. Anesthesia providers are often called anywhere in the hospital for emergency airway management as well. In the military, anesthesia providers also provide care in the field. In conclusion, I will discuss the application of the components of MAC and conscious sedation. The ASA states that in providing MAC, the anesthesia provider must provide the following services. A pre-procedure visit. The anesthesia provider must perform a thorough pre-anesthetic examination and evaluation as discussed earlier. The patient and or legal guardian must be informed regarding the planned anesthesia care, and a consent for sedation and analgesia must be obtained. The pre-anesthetic evaluation plan should strive to identify specific causes of and provide specific therapy for pain, anxiety, and agitation. Intra-procedure care includes the continuous presence of the anesthesia provider and vigilance in supporting the patient's vital functions. The standards for basic monitoring must be employed. The patient's oxygenation, ventilation, and circulation status must be monitored continuously. This also includes the administration of sedatives, analgesics, hypnotics, anesthetic agents, or other medications as necessary for patient safety. Post-procedure management includes the continuous assessment of the patient's physiologic status. Appropriate disposition, whether discharge or admission and transport to another location, must be coordinated safely as the patient recovers from sedation or anesthesia. Here is an example technique for monitored anesthesia care from Jaffe and only act as a guideline for otherwise healthy 70-kilogram patient. As with everything, specific drugs and drug dosages should be individualized based on patient status and associated comorbidities. Standard monitoring with regular verbal contact, O2 via nasal or face mask. Light to moderate sedation levels can be obtained using a propofol infusion, with or without intermittent boluses injections of midazolam, with or without fentanyl, or with a remifentanil infusion, titrated to effect. Monitor closely for respiratory depression. Alternatively, one can use dexmedetomidine, which can produce excellent sedation and analgesia without respiratory depression. The loading dose is typically 1 microgram per kilogram IV over 15 minutes, followed by infusion of 0.2 to 0.7 microgram per kilogram per hour. If the initial local anesthetic injection will be painful, such as for a retrobulbar block, then a brief period of analgesia, sedation, and amnesia may be induced with midazolam, with or without ketamine, with or without alfentanil or remifentanil. Propofol with or without fentanyl can also be used. Here are two current literature on dexmedetomidine and fospropofol regarding their use in monitored anesthesia care. A prospective randomized double-blind multi-center study of 326 patients showed that dexmedetomidine is an effective baseline sedative for patients undergoing MAC, providing better patient satisfaction, less opioid requirements, and less respiratory depression than placebo rescued with midazolam and fentanyl. Another article I found showed that fospropofol, a prodrug version of propofol, showed clinically useful sedation while causing significantly less respiratory depression than propofol with no pain on injection. The main complaint is, however, transient perianal itching occurring approximately 1 minute after injection and resolves in 2 to 3 minutes. Here are my references, and let me know if you need a copy of the two articles and I can send them to you. Thank you very much for your time. If you have any questions, please let me know. Have a great day.